Good afternoon, everyone. I'm Dr. Ritika, resident from Department of Psychiatry. Today, we will be discussing the topic Importance of Learning Theories in the Management of Psychiatric Disorders. Firstly, the contents of our topic are Introduction, Learning Theories, Classical Conditioning, Clinical Applications of Classical Conditioning, Operant Conditioning, and Clinical Applications of Operant Conditioning, Cognitive Learning Theory and its Clinical Applications, Social Learning Theory and its Clinical Applications, Conclusion, and then references. First is introduction to the topic. It includes the definition of learning. Learning is defined as any relatively permanent change in behavior and knowledge resulting from repeated practice and experience. The change can be either better or worse. It is not due to growth or maturation, not a temporary behavior effect, but it is a permanent change in behavior. The learning theories are classical conditioning, operant conditioning, cognitive learning, and social learning. First, we will discuss the classical conditioning. Classical conditioning is a type of learning in which a stimulus acquires the capacity to evoke a response that was originally evoked by another stimulus. It means a response was produced. Firstly, one stimulus is presented and then same response is produced by a new stimulus. It was first described by Ivan P. Pavlov and is also known as respondent or Pavlovian conditioning. In classical conditioning, two stimuli are presented to the learner. First is conditioned stimulus, then is unconditioned stimulus. Conditioned stimulus is also known as neutral stimulus because it does not evoke a specific response except for alerting or attentional response for first few times of presentation. And the unconditioned stimulus is a stimulus which evokes a specific response. The response to unconditioned stimulus without previous conditioning is unconditioned response. After both the stimuli have been paired a number of times or many trials are done, presentation of the original neutral conditioned stimulus evokes a response. This is called conditioned response. Here is an example of a Pavlovian experiment in which an unconditioned stimulus is a food. When this unconditioned stimulus is presented to the dog, it produces a response that is unconditioned response in the form of salivation. And this unconditioned stimulus, that is food, is paired with the conditioned stimulus, that is bell. In this experiment, every time the bell is rung, which is the conditioned stimulus, and food is presented to the dog, which produces the unconditioned response, that is salivation. And after a number of repetitions, the next time the conditioned stimulus is presented, the response produced will be salivation, and this is called conditioned response. The same response is produced to the conditioned stimulus. And this clinical applications of classical conditioning are: first is systematic desensitization. It was first developed by Joseph Wall in 1958. In this, the gradual exposure of the subject to the feared stimulus or situation by one step at a time. The subject is exposed to the feared stimulus gradually, and it is done in 3 steps. First is relaxation training, and hierarchy construction, and desensitization of the stimulus. First, in relaxation training, we produce the physiological effects of anxiety, physiological responses that are opposite to that are produced in anxiety. And patient is relaxed it can be done by yoga or deep breathing exercises. Next, in hierarchy construction, a hierarchy is constructed in the form of patients like feared stimuli in the form of increasing level of anxiety. Then patient is being desensitized from that stimulus. It can be used in disorders like obsessive compulsive disorder, phobias, and post-traumatic stress disorder. Example can be given as once, for example, a patient is afraid of or having phobia of spiders. Then firstly, we can talk about the spiders. Then we can present a drawing picture to in front of the patient. Then the spider can be shown far away from the patient, then close to the patient, then patient can be asked to touch it. In this graded exposure, patient become can be treated for phobia. Second is counter-attacking. It works on the principle that hard countering is both an emotional and intellectual process. Emotions are paired with beliefs. Person's strong emotion can change the belief. This can be strengthened by using physical exertion or voice modulation. Physical exertion can be in the form like patient, every time patient is having any irrational thought, he can contract his muscles in the form of increasing intensity of contraction. And in voice modulation can be increasing intensity or loudness of voice every time the patient is having irrational thoughts. So it can be used in the management of depression and anxiety disorders. Third one is flooding, in which presentation of feared or aversive condition stimulus for long periods of time leads to dissipation of that anxiety. The patient is exposed to the feared stimulus for a long period of time. It works on the principle of removing a conditioned avoidance response. The methods done can be by image flooding, verbal flooding, or focused flooding. In image flooding, patient is asked to imagine the feared scene and irrational thoughts until the conditioned response, which can be in the form of anxiety, until that response subsides, patient is asked to imagine that scene for a prolonged period of time. And in verbal flooding, we ask the patient to discuss the event that or the feared stimuli multiple number of times until the patient becomes tired of discussing the topic. Third one is focused flooding, in which patient is asked to focus on the conditioned response, that is the effects of anxiety, physiological effects of anxiety. He is asked to focus on the response only. It is used for the management of phobias and obsessive compulsive disorders. This should not be used in schizophrenic patients who are afraid of hallucinations or depressive patients who are afraid of committing suicide. And fourth one is extinction. It works on the principle of imagination of the conditioned stimulus without unconditioned stimulus. Extinction erases the previous association or a new learning replaces the old. Can be used in panic disorder, phobias, or PTSD. Example can be given as the once the patient was driving a car and carbon dioxide started leaking from the car, and patient developed breathing problems that lead to severe anxiety. And every time patient used to drive the car, patient used to have anxiety that the carbon dioxide leakage, or he can have breathing problems with that. So the conditioned stimulus is when the patient drives a car, and we have to present the patient, ask the patient to drive a car next time, but it should be made sure that the unconditioned stimulus, like it was carbon monoxide leakage, it should not be present at that time. This removes the earlier response, that was anxiety. Next one is aversive therapy. It is the pairing of an unpleasant or noxious stimulus with a target behavior. Methods done can be like self-punishment, standard aversive images, and physical aversion. In self-punishment, patient is asked, whenever patient is having any irrational thought, then the patient is asked to think of the worst possible consequence of that thought. So the patient can feel that this might produce a bad consequences, so the patient stops thinking about those irrational thoughts. Then standard aversive images are present in the form of snakes or vomiting that are presented to the patient every time the patient is having any irrational thought. Then physical aversion can be patient is asked to snap the rubber band tied on the wrist and say stop while having any irrational thought. And it can be used in the management of drug addiction also, like in alcohol, disulfiram reaction is there. Whenever the patient uses alcohol while taking disulfiram tablet, the patient can have aversive responses like nausea, vomiting, flushing, or any other, can cause severe cardiological effects. Then second one is operant conditioning. It is a form of learning in which response is controlled by the consequences of the behavior. It was first studied by Edward Thorndike. It works on law of effect theory. The principle that responses can create pleasant outcome in a particular situation are more likely to occur again in the similar situation. This learning was termed as instrumental theory. Reinforcement. The environmental event occurring as a consequence of an instrumental response, and that increases the probability of the response to occur again. If the person is reinforced with some pleasant thing, this same response can occur again. It increases the likelihood of the response to occur again. Reinforcement can be positive as well as negative. In positive reinforcement, it strengthens a response by presenting a positive stimulus after a response. And in negative reinforcement, it strengthens a response by removing an aversive stimulus after a response. Punishment is any event that reduces the likelihood of the behavior. If you punish someone, that can reduce the likelihood of that behavior, which is punishment should be consistent, having temporal relationship and non-physical and strong enough to have an impact to that behavior. Clinical applications of operant conditioning. First is token economy and star charts. It was introduced by Island and Azreen in 1968. It was used to modify the behavior of patients in psychiatric wards. Principle used is positive reinforcement. It can be used in schizophrenic patients, oppositional defiant disorder, ADHD, and for children, star cards are used. It is used as a positive reinforcement to improve the behavior, to get the desired behavior. Second one is differential reinforcement of other behavior, like reinforcement of positive behaviors rather than focusing on undesirable ones. For example, if a child is having a phobia of adult dogs, it can be rewarded by looking for a puppy. And patient, if that child looks towards the puppy and does not having fear, that child can be rewarded with something that child like, that can be sweets also. So the phobia of adults can be reduced. For substance dependent patients, administration of a non-drug reinforcer after abstinence is maintained. Then is biofeedback. Continuous feedback is provided regarding one's physiological states like blood pressure, heart rate in the form of auditory or visual signals. The individual attempts to control the signals voluntarily using methods that have been taught and is used in relaxation training. It can be used for the management of anxiety disorders, mainly the generalized anxiety disorder, and in tension headache also. Then is negative reinforcement. It is non-reinforcement of the undesired behavior. It can be used in the form of timeout or response cost. First is timeout. It's a form of negative reinforcement in which person is removed from all the positive reinforcing events from a brief periods of time. For example, two siblings are fighting and they are removed from, they are asked to sit away from each other. And the positive reinforcement that can be attention towards them should be removed, and this can help in improving their behavior. Then is response cost is the removal of the positive event as a response to undesirable behavior. If the child does any undesirable behavior, any positive thing they like can be removed. They should not be given that thing that they like. It can be used in temper tantrums, oppositional defiant disorder, and other disruptive behavior disorders. Punishment can be physical punishment in children in modeling of aggressive behavior, but physical punishment provokes intense feelings of anger and resentment. Then is cognitive learning. This theory is based on mental processes such as thinking and development of decision rules. It can be used in paradoxical intention for non-pharmacological management of insomnia. Like patient is having any problem of insomnia is asked not to try to fall asleep. It can help in improving the performance anxiety to fall asleep also, and can be used in PTSD, decreased self-esteem, and depressive disorder. Cognitive learning is also used in mild to moderate dementia, in which a guided practice of set of structured tasks for improving mental abilities like memory, attention, or problem solving are presented to the patient. Observation learning, it is by observing the behavior of others. It can be also helpful in participant modeling, like improving the behavior of the parents of the child and how they should behave in front of the child this can be taught by the therapist to the patient. And cognitive factors involved in our attention, retention, reproduction, and motivation. Attention is the person is asked to attentively see our behavior, and then retention of the same behavior, and reproduction is to behave in the same way whenever it is expected, and that person should be motivated to perform that behavior whenever it is required. It can be used in management of phobias also. Then social learning theory, it was given by Albert Bandura in 1986, based on the complex human learning and behavior in terms of thought processes. It works on the principle of reciprocal determinism, as social learning is based on the three things, that is behavior, personal factors, and environment of the human beings. It can be done by self-regulation. Self-regulation is ability to regulate one's behavior. That can be by self-observation and self-evaluation. Self-observation is monitoring of oneself relative to others with expected standards. And self-evaluation is judgmental process of one's performance. It can be used in depression, conduct disorder, aggressive behavior disorder, and criminality in young people. In conclusion, I would like to conclude my topic as learning is any relatively permanent change in behavior in knowledge resulting from the repeated practice and experience. It is not through the growth and maturation. And systematic desensitization can be used in the management of OCD, phobias, and PTSD. Flooding in management of phobias, PTSD, and OCD. Extinction for panic disorder and phobias. And aversive therapy used for management of substance use disorders. Then operant conditioning, token economy for treatment of schizophrenia, not for treatment but managing the patients in the inpatient setups, and disruptive behavior disorders. Differential reinforcement of other behaviors for management of phobias and addiction. Biofeedbacks for anxiety disorders and also tension headache. Negative reinforcement for management of disruptive behavior of especially of children. Cognitive learning for paradoxical intention to non-pharmacological management of insomnia, PTSD, decreased self-esteem and depression. And then social learning can be used for management of depression, conduct disorder, aggressive behavior, and criminality in young people. Thank you.